Hi, everyone. I'm Enrico Asher, the Executive Director of the Frank J. Veith International Society, and pleased to welcome you to today's webinar on pelvic venous disorders. This group of medical conditions can cause a range of symptoms, including chronic pelvic pain, flank pain, varicose veins in the lower abdomen and legs, and painful intercourse. In today's webinar, we will be discussing the different types of pelvic venous disorders, their causes, and how they are diagnosed and treated. We will also be discussing best practices for managing these conditions, and we hope that this webinar will provide you with valuable insights. Our expert panel and speakers and distinguished discussants include leading clinicians and researchers in the field of pelvic venous disorders. They will share their expertise and answer your questions during the Q&A session. Later this afternoon, you will find this entire program posted at www.vsymposium.org at that website. Indeed, all our previous webinars can be accessed for free at that website. I will be remiss if I don't highlight the participation of the legendary Dr. Frank Veith. Thank you, Frank, for your continued support to the FJV societies. Also, I want to extend our sincere thanks to Pauline Mayer and Jackie Simpson for their invaluable and expert organizational support. Without further delay, I would like to invite our moderators, Dr. Klovitsky and Lurie, Doctors Klovitsky and Lurie, to lead this webinar. Dr. Peter Klovitsky is also the president of this society, and I would like to thank him for putting together the scientific program. Both him and Dr. Fedor Lurie are recognized experts in this subject. Peter, please.
Thank you very much, Dr. Asher. Good morning or good evening, everyone, wherever you are. It's a real pleasure to lead a discussion on contemporary management of pelvic venous disorders. Millions of women and some men are affected with chronic pelvic pain around the world, and in the United States, about 6 to 7 million women have chronic venous disorders. The discussion will be interesting because progress in this field has been tremendous. We have new classification, we have new minimally invasive techniques, and we have a lot of published literature on the subject, and we have many experts who will talk about the data. It is a pleasure to introduce my co-moderator, Dr. Fedor Lurie, who is also going to be our first speaker. Dr. Lurie is adjunct research professor at the University of Michigan and associate director of JOPS Vascular Institute at Toledo, Ohio. And the title of his presentation is Classification and Clinical Presentation of Patients with Pelvic Venous Disorders. Dr. Lurie?
Peter, thank you very much for your introduction, and thank everybody who is listening to this webinar. I hope that you see my slides now. Yeah, you do. Okay, so classification and clinical presentations of patients with pelvic disorders. I have no conflicts of interest. I think we all have seen patients similar to this 45-year-old school teacher. At the age of 25, she had noticed few varices in the inguinal area, and 5 years later, after her second pregnancy, she developed pelvic pain, dyspareunia, and ache in this area of these varices. A local vein clinic treated her with cosmetic sclerotherapy and no imaging. And later, she was diagnosed with endometriosis and underwent hysterectomy. 5 years later, MRV shows enlarged left ovarian vein, and the venogram shows left renal vein obstruction and ovarian reflux. So why did it take so long to diagnose pelvic venous disorders? Well, the challenges are many, but the lack of uniform terminology and classification play a critical role. There is no published data that is convincing enough to demonstrate the place of venous disorders in the spectrum of pelvic pain. Evaluation of patients in clinical practices is variable, and so are the treatment outcomes, which enforces skepticism in gynecologists and primary care physicians. Such situation is actually quite surprising because the underlying pathophysiology of pelvic venous disorders are well studied and documented. So there is only 5 segments in the inferior vena cava system that are usually affected. Left renal vein and iliac veins can be affected by obstruction, either as a result of external compression or thrombosis, congenital abnormalities, or combination of them. The second pathology is reflux in Canadian veins and pelvic vein escapes. These pathologies, of course, can be combined or be isolated in every single patient. Well, the result of these pathologies increased venous pressure and overextension of venous reservoirs. Hypertension and left venous reservoir, left renal venous reservoir may manifest as hematuria and flank pain, but it also may remain silent in diseases compensated. A pelvic reservoir may also be silent or cause pelvic pain, dyspareunia, and dysuria. Connected by pelvic escape points, lower extremity veins may also be affected. The symptoms are the same as other venous disorders, but the location of varices points to connection to pelvic veins. The new SVP classification takes this established knowledge as a basis. It assigns each of the domains to an anatomical zone. So zone 1 corresponds to the left renal vein, zone 2 to gonadal veins, iliac veins, and pelvic venous plexuses, zone 3 to extra pelvic veins connected through the escape point to zone 4, which is assigned to lower extremity veins where CAP classification should be used in addition to SVP classification. Although the system may appear as a complicated, it's actually quite easy to use. All you have to do is to assign each of 3 domains to the anatomical zone of the likely origin. So flank pain points to the possible involvement of renal reservoir and should be denoted as S1, pelvic pain as S2, and extrapelvic symptoms as S3. Varices identified by clinical examination or by imaging followed the same system of notation. And pathophysiology has 3 subdomains. The common abbreviation I use to indicate the affected venous segments. Hemodynamics is noted as obstruction, reflux, or both, and etiology divided into thrombotic, non-thrombotic, and congenital. The practical aspect of SVP instrument is important, I think. A patient with venous disorders should be investigated to confirm or exclude each of the domains and subdomains of SVP. Inability to complete the entire SVP classification indicates incomplete patient examination and should be considered as less than appropriate care. I would add to that this same is true for patients with any chronic pelvic pain. One cannot really exclude pelvic vein disorder unless all information listed in SVP is available. So here is our patient. You can appreciate that incomplete investigation on 2 occasions had led to selection of ineffective treatment options. Well, some of them are relatively benign, but the other made a dramatic change in patient's life. More complete investigation resulted in a better clinical outcome. That demonstrates that SVP classification may and I think should be used to guide clinical evaluation in routine practice. In conclusion, the SVP is a comprehensive descriptive instrument which provides precise definition of patient populations for clinical trials and observational studies, but it also provides clinical guidance for evaluation of patients with chronic pelvic pain, and the ability to complete the entire SVP classification indicates completeness of investigation of patients with pelvic venous disorders. Thank you very much for your attention.
Thank you very much, Fedor. This was an excellent summary of the new classification that hopefully will be soon accepted worldwide. Dr. Frank Veith is going to discuss and ask a key question. Dr. Veith, of course, needs no introduction. He is professor at Cleveland Clinic Lerner College of Medicine and at New York University Medical Center. Frank, please go ahead.
Yeah, Peter, thank you so much. And first, I'd like to congratulate you and Rico and Dr. Laurie on putting this very interesting webinar together. It's a fascinating subject, and we really all of us need to know more about it. Dr. Laurie, I thought that was a very clear and well-organized description of a classification system. I guess my burning question is for the typical vascular surgeon or even non-vascular doctor, if you see a young woman who's got flank pain, maybe some lower abdominal pain, when do you start working them up for pelvic venous disorders if they don't have any vulvar or upper thigh varicosities?
Well, Dr. Veith, thank you. Of course, I would expect from you just a question that I cannot really answer as expected, but it's a really good one. I think that for patients with pelvic pain and suspected venous origin of this pain, that should be a really collaboration between the vascular surgeon and OBGYN, and that's sometimes in some institutions it's a challenge, and that needs to be resolved, because the reality is that the venous etiology is just one of many causes of pelvic pain, and sometimes those causes are combined together. So we really need to be on both sides of that. But I think from what you described, but if somebody has a flank pain, especially if it's a standing and sitting upright position, that should be investigated from the vascular perspective, starting with the minimally invasive, at least ultrasound examination, looking at probably enlarged ovarian veins, and then go into more complex examination of those patients.
But your message is always think about it, right?
I think that's exactly right. I think you should think about possible venous cause in every chronic pain.
Thank you very much. I think we are going to learn much more how to evaluate and when to intervene in chronic venous disorders. And now, please, Fedor, introduce our next speaker.
Yes, now next speaker is Dr. Neil Kilani. I don't think he also needs any introduction. He is a past president of the American Venous and Lymphatic Society, and he is a co-author of this classification. So if you have any concern about this, he will be the person to address that. And the title of his presentation is Symptoms and Signs of Venous Origin Chronic Pelvic Pain. Neil, go ahead.
Thank you, Fedor. And thank you to Peter and the rest of the group for inviting me. It's an honor to be part of this webinar. Although Dr. Veith and I have never really met, I've certainly enjoyed listening to his lectures over the years, and I need to be one of the few people who can say they've actually witnessed him windsurfing on Long Island. When I was a resident, I happened to have that opportunity. So I was windsurfing next to him, and I said, I know him. So at some point we do need to meet in person, but thank you for the opportunity. And again, I'm in New York at Cornell, and that was the topic that Fedor pointed out. My disclosures is I've done some scientific advisory board work for Medtronic on this topic. I've got grant support in this area related to some projects that we could talk about later from the SIR Foundation. And I do want to value the support I've had from a number of colleagues who've worked with us, many of whom were on that SVP document as authors in a pelvic disease work group. It's a work group that is composed of vascular interventionalists, but also gynecologists. And as was mentioned by Dr. Laurie, these are the physicians who are taking care of many of these women that we're talking about today with chronic pelvic pain, and sharing ideas and getting their perspective and our perspective out in the open has been a very eye-opening experience for me and for them, and has led to some of the conclusions that at least we're going to share with you today in our talk. So there are a number of issues that can lead to chronic pelvic pain, and this is beyond the scope of today's talk, but our goal in our evaluating these patients is to find the ones that are related, the patients that are affected by a venous disorder. And as it turns out, the differential narrows very dramatically when you consider what other issues are related or produce symptoms that are similar to those of venous disorder. And it really comes down to endometriosis, which actually is quite easy to distinguish, and myofascial pain, pelvic floor myalgia, which is really where the challenges develop. And so the classically described clinical criteria for venous origin chronic pelvic pain are derived from some work by Dr. Beard, who studied patients by their history and physical exam, and also with venography. And he did this back in 1988, and there was some additional work done in the 1990s. He's a gynecologist from England, and some of his work got lost for a few years. And we've resurrected it, and I'll try to distill his comments, which I think still hold true in our impressions today. So the symptoms that are of venous origin for chronic pelvic pain are those that are provoked by gravity. So things that get worse with long standing, after a long period of walking at the end of the day, and conversely get better when patients lie down. And if a woman happens to be sexually active, can result in prolonged postcoital aching. We can't forget the physical exam also plays a role in making these diagnoses, and I will highlight that later. But as a clinical sign, he identified that there was a diffuse tenderness to the uterus and perimetrial areas that could, in many cases, reproduce the pain that the patients were complaining about. And so I'm going to go through some of the work that has been put together to identify patients so that we can do clinical trials. You know, I think one of the key things I think we'll all agree is in order to do clinical trials on patients with this problem, we need a very homogeneous population. And so we need to, as best as we can, exclude other issues and identify, in many ways, partially indirectly and partially directly, those patients with pelvic venous disorders. So features in the history that favor dysmenorrhea are this cramping dysmenorrhea that crescendos at the time of menstruation, and then very soon after disappears with a consistent pain-free interval between. That's very different than what we see with our pelvic venous disorders. They have deep dyspareunia, not entry dyspareunia, and unusual to have prolonged postcoital aching if it's the only thing they have. And certainly there's no change in the time of the day, no change with position, and endometriosis can be improved with combined oral contraceptives and progestins. If we look at the history that we talked about with regard to pelvic venous disorders, we described pain-free in the morning, worse with gravity, better with lying down, prolonged postcoital aching, deep dyspareunia, and no significant relief with combined oral contraceptives. If we look at the patients with pelvic floor myalgia, a very common diagnosis in the gynecologic community for chronic pelvic pain, you'll notice that the features I'm going to toggle through without reading them are very similar. In fact, they overlap so much that it's very difficult for the gynecologist to distinguish it. And this may be the group of patients that they are treating with pelvic floor myalgia that may benefit from an evaluation for venous disorders. There are some differences. Pelvic floor myalgia generally gets better with non-steroidal anti-inflammatories, where venous disorders don't. And venous disorders usually don't get better with opioids. And there's no response to ovarian suppression with pelvic floor myalgia, but the pelvic venous disorders from reflux do get better with ovarian suppression. The physical exam is necessary to distinguish, and I think as we get to Alex's opportunity to speak, she'll echo this as a gynecologist, as a speaker later in this session. But the external evaluation can identify parametrial discomfort by palpating over the ovarian points, a point 1/3 of the distance from the umbilicus to the anterior superior iliac spine. But to be complete, a true bimanual examination needs to be done with a very systematic, thorough examination of all the structures of the pelvic floor, as well as all the reproductive organs and colon and bladder. And this requires special training and experience, and is usually not something that most gynecologists do. And in addition, a very thorough musculoskeletal exam, including of the intra-abdominal wall, the hips, the back, the thighs, is done because many of the patients with the myofascial pain syndrome will be only identified with that part of the physical exam. So when you get to the physical exam, what favors endometriosis is a focal retrocervical tenderness that can reproduce the dyspareunia with or without adnexal pain and with or without nodules, but certainly no ovarian point tenderness is a rule, and no musculoskeletal or abdominal wall tenderness unless there's a patient with central sensitization, which we'll talk about in a moment. What favors pelvic floor myalgia are no, again, pelvic ovarian point tenderness, no uterine or adnexal tenderness at all, but tenderness in the abdominal wall in the pelvic floor, along with pelvic floor high tone. And often you can reproduce the pain by pushing on specific muscle groups in patients with pelvic floor myalgia. Patients with PEVD tend to have more diffuse pain. Again, the ovarian point palpation may lead to pain, and on bimanual exam, the uterus or the adnexa may be tender. And again, that may reproduce the pain that the patient's complaining about, particularly the deep dyspareunia that they often have. They may have abnormal veins on their vulva, on their thigh, and on their abdominal wall, as Dr. Veith had alluded to as well, but specifically no pelvic floor tenderness, unless again, they have central sensitization. Clearly, imaging plays an extremely supportive role in this case. A patient who meets the criteria for a pelvic venous disorder based on history and physical exam, and who has an ultrasound or a CT or an MRI that looks like this, certainly is a candidate for further evaluation and possible treatment. We need to recognize, though, that there are a lot of patients walking around with these kind of varicosities in their pelvis who are asymptomatic, much like we see with patients with varicose veins in their legs. So to summarize, in terms of trying to do the best for the patients and in terms of who we select for treatment, we need to identify the black sheep amongst the white and identify those with pelvic venous disorders from all the other distractors. The main distractor turns out to be pelvic floor myalgia, not endometriosis. They have very similar histories, and it's the physical exam with an experienced physical exam that helps to make the distinction. And the imaging diagnosis is a confirmatory thing. Several conditions may coexist in patients, and so they may have several different pain generators. And as I pointed out, central sensitization is a very common issue where, if you will, referred pain to other organs occurs after chronic pain has been in place for a while. It's true in all parts of the body, and pelvis is no exception. And many times we're actually dealing with a mixture of different symptoms, and we need to use the experienced selection advice that we can get from our colleagues who are chronic pain, pelvic pain specialists to identify which are the important pelvic pain generators to address first. But there's definitely a role for engaging with other providers to treat other coexisting primary and potentially secondary pain generators that can occur in these patients to maximally enhance our impact in terms of their care. So again, thank you for the opportunity to speak, and I look forward to the discussion that follows.
So our discussant for this topic is Dr. Harold Bjarnason from Mayo Clinic in Rochester, Minnesota, is another expert on venous intervention. So go ahead, what's your comment and burning question?
Thank you. I really enjoyed that talk, and I'm so excited to see the enthusiasm that is building up around this aspect of venous disease, and also the complexity that we are understanding that venous obstruction and incompetence plays in not only this, but many other aspects. We originally thought that ovarian vein incompetence was responsible for most of pelvic congestion or pelvic pain was from a venous, but now more recently, as was pointed out by Fedor, we are understanding also that iliac vein compression may play a role, and maybe some other things. So you enlisted very nicely the clinical presentation, Neil. I'm curious, we often see patients without compression, without reflux, or without large ovarian veins, but we see they have compression of the common iliac vein. Is there any way based on what you enlisted, to kind of differentiate between the patients that have pelvic pain caused by venous compression, the iliac veins, as compared to the ovarian veins?
Yeah, thank you, Haraldur. That's an extremely important question, and it raises perhaps something I should have pointed out a little more clearly, is that Beard, when developing the criteria, and all those who followed have made the inference that it was reflux that was associated with these symptoms. We clearly know that there are patients who have treatment for obstruction of their iliac veins who benefit. The challenge is to identify perhaps either signaling symptoms that may be different in those particular patients, to distinguish patients who have primarily pain from obstruction as opposed to pain from reflux, given the fact that the two can coexist in the same patient. And the answer to your question is we really don't know. And I think this is an opportunity for us to do some more research. You know, we don't know if there's a difference in symptoms. Certainly, some features that we could raise that may help signal obstruction as more common or as a more likely pain generator than reflux would be a younger woman. So if you had a woman who's in her late teens or 20s who has significant pelvic pain, no other cause, and a severe obstruction, generally these would be nulliparous women. So that's another feature of this perhaps cohort. Maybe that's a group where obstruction may be a little bit more likely. And looking on the other extreme of the reproductive period, those who are perimenopausal or postmenopausal, who present with progressive pain later in their lives, in spite of the fact that generally the impression is that patients with reflux-related pain improve post menopause. That may be another feature. And certainly when we see patients with other symptoms, perhaps leg swelling or leg aching ipsilateral to the obstruction, those are some other features. But I think at this point, these are just anecdotal observations, and we do need to collect some data and try to figure out how to distinguish these patients. And it may turn out that much of the symptomatology overlaps, as we'll probably find with many of these chronic pelvic pain generating conditions beyond vascular conditions. So thank you for that question.
Thank you very much. And I'll ask Dr. Glavitsky to introduce our next speaker.
Thank you very much, Neil. That was an excellent presentation, and introduces actually the further topics on this webinar. And it's a real pleasure to introduce another expert who has had a long interest in pelvic pain. John Veith is chair of surgery at the Advocate Lutheran General Hospital and clinical professor of surgery at the University of Illinois College of Medicine. And John is going to address the issue of the ovarian vein and a specific procedure, the left ovarian vein transposition. John?
Thanks very much, Peter. I would like to extend my congratulations to you and Enrico and Fedor for developing such an outstanding symposium for the Frank J. Veith International Society. And I'd like to thank you for the privilege of presenting some of our information. I have no conflicts of interest. Nutcracker syndrome is caused by compression of the left renal vein between the superior mesenteric artery and the aorta. This is increasingly recognized as an underlying cause of pelvic venous disease and chronic pelvic pain. The compression of the renal vein causes elevated pressures within that vein, which are transmitted to the kidney, generating left flank pain and intermittent hematuria. For women with Nutcracker syndrome, these classic symptoms of left flank pain and intermittent hematuria tend to resolve when left ovarian vein reflux is sufficient to lower the left renal vein pressure. Unfortunately, the reflux flows into the tiny veins of the pampiniform plexus and the parametrial veins, causing pelvic venous disease with symptoms of chronic pelvic pain, dyspareunia, and worsening menses. We evaluate women with pelvic venous disease confirmed by transvaginal duplex imaging for nutcracker syndrome using CT venography of the abdomen and pelvis and tilt table venography with IVUS to fully image and evaluate the inferior vena cava and bilateral renal, ovarian, and iliac veins. Our criteria to confirm the diagnosis of nutcracker syndrome include a 70% or greater compression of the left renal vein, reflux from the left renal vein into collateral veins, such as the ovarian vein, and finally, and importantly, flow from large to small diameter veins, suggesting a high reflux driving pressure from the left renal vein. If nutcracker syndrome and pelvic venous disease confirmed, we offer left ovarian vein transposition to the left iliac vein for all women with an ovarian vein 5 millimeters or larger in diameter throughout its course. The operation takes advantage of the simple anatomy that the left ovarian vein crosses directly over the left iliac vein. The purpose of the transposition is to optimize reflux in the left ovarian vein to maintain low renal vein pressures while reducing flow into the pelvic varicose veins and eradicating the associated symptoms. The simple procedure is performed through a curvilinear incision in the left lower quadrant of the abdomen. A standard retroperitoneal approach is taken by opening the anterior sheath, retracting the rectus muscle and its blood supply medially, and then dividing the posterior sheath to expose the anterior surface of the peritoneum. The peritoneal sac itself, with the attached ureter and ovarian vein, is retracted medially. The iliac artery is retracted laterally to expose the medial aspect of the iliac vein. It is cleared sufficiently to permit placement of a side-biting clamp. Once done, retraction on the peritoneal sac is reduced to bring the ovarian vein back into view. The areolar tissue anchoring the ovarian vein to the posterior peritoneum is then sharply divided. Approximately 3 centimeters of ovarian vein is freed from surrounding tissue to come over to the iliac vein without any tension. After systemic heparinization, the distal ovarian vein is ligated with 2O silk ties. The proximal vein is occluded with a Yasser-Gill clip, and a single stay stitch of 6-O-proline is placed to facilitate orientation and retraction. The ovarian vein is then divided. A side-biting clamp is placed upon the iliac vein to include a 2-centimeter segment of iliac vein. A 15-millimeter venotomy is made in the medial wall of the iliac vein, and the ovarian vein is spatulated a similar length. An endoside anastomosis is constructed using continuous 6-O-proline suture. Once the anastomosis is completed and secured, flow is initiated into this venous segment. The hemostasis is easily achieved because it's a generally low pressure system, and a Doppler is used to confirm that the flow from the ovarian vein is entering the iliac vein. This presentation reflects the results of our initial 12 patients selected from 22 women with confirmed nutcracker syndrome identified during the evaluation of 190 women with chronic pelvic pain of unknown etiology. The average age of our patients was just under 40 years. The procedure, which took approximately 2.5 hours, was successful in all 12. There was one acute complication, which was bleeding from a pressure cannula site in the left ovarian vein. This required immediate return to the operating room for treatment. The patient subsequently did well. There were no delayed 30-day complications. The length of stay is under 2 days. With a mean follow-up of more than 4 years, 92% of the transposed ovarian veins remained patent. The single occlusion was a 3 to 4 millimeter ovarian vein. There were no instances of left iliac vein clot or suggestion of left leg venous outflow compromise. To confirm that the procedure was of value to these women in improving their quality of life and reducing some of the pain, we asked that each of the patients complete an SF-36 quality of life survey prior to and then more than 1 month after surgery. As you comparing pre and postoperative scores, one can see that the transposition of the left ovarian vein to the left iliac vein leads to an overall improvement in quality of life. There was improvement in all domains of the SF-36. Overall health change, role limitations due to physical disabilities, overall energy levels, and pain levels were significantly improved with p-values of less than or equal to 0.01. So from these data, we've concluded that left ovarian vein transposition to the left iliac vein in select patients is a simple procedure that optimizes reflux from the left renal vein to the left iliac vein to maintain low renal vein pressures and reduces or eliminates flow into the pelvic varicose veins. It significantly improves the quality of life for those women with Nutcracker syndrome and symptoms of pelvic venous disease. I'd like to thank you for your kind attention.
Thank you very much, John. This was a super presentation with a beautiful video. It's such a pleasure to see a minimally invasive procedure being so effective today when most of these procedures are performed endovascularly. Sarah Onida is our international discussant. Sarah joins us from the Imperial College in London. And she has a comment and a burning question. Dr. Onida.
Thank you very much, Dr. Glowicki. First of all, I'd like to congratulate everyone for this fantastic webinar, and it's on a really important group of patients on an important topic. I would also like to congratulate Dr. White for the excellent presentation and for the excellent outcomes that he has, but also for the assessment of quality of life that he has performed in his patients, because clearly that's a really important point that must always be assessed in our patients. And I think you've got some really interesting results there. Now, I had a very specific comment with respect to the actual procedure. Then I had another quick burning question. So my quick specific comment is, with respect to your anticoagulation regimen following this intervention, what is your practice? How do you anticoagulate them? Do you anticoagulate them for how long? And how do you follow them up following the procedure in terms of making sure that things are still running smoothly and they are well? And the second comment is, clearly these are patients that are a very select group of patients. We saw that there were many women that were screened for pelvic pain, and very few actually fit the anatomical criteria to then go on and have this procedure. What sort of workup do these women have with respect to other team members and a multidisciplinary approach to try and make sure that they are best equipped to then face the operation and have the best possible outcome in your experience? Thank you.
Thank you, Dr. Onida. Those are all excellent questions. So first, with regard to anticoagulation, we systemically anticoagulate during the procedure, and we therapeutically anticoagulate for 3 months post-procedure. And I must admit that this is simply based upon anecdotal experience with these patients. I will tell you that as we all recognize, that therapeutic anticoagulation in young menstruating women can be almost a life-threatening problem with blood loss during menses. So in those patients, we will use PLAVIX instead of Xarelto or Eliquis. But we do like to at least give them 3 months of treatment. Subsequently, we may reduce them to a baby aspirin, again, based upon anecdotal evidence, so that we feel comfortable that they're not going to have any issues with the left iliac vein, which was one of our big concerns when we began this procedure. In terms of follow-up, we use duplex imaging to confirm flow in the ovarian vein. If there's flow postoperatively in the ovarian vein, then clearly the anastomosis is patent and we're achieving our results. If there's a question, our second line is CT venography. And if there are still questions, then we are great fans of tilt table reverse Trendelenburg contrast venography. So those are the studies we tend to use. In terms of the workup for these patients, we do have a multidisciplinary group that meets once a month to review all of these women, and that includes our gynecologists, our interventional radiologists, and our vascular surgeons. And I must admit that we do not begin treatment of any woman that has not had a full gynecologic evaluation. My biggest fear is that jumping into treatment of pelvic varicose veins without confirming that a young woman doesn't have an ovarian cancer or something more serious, I think is absolutely essential. So we have found that our highest yield in identifying patients with pelvic venous disease is when our gynecologists fully evaluate the patient, especially with laparoscopy, and then find no specific cause of the pain. When we venogram those patients, our positive venography moved from 45% when we did all comers to 95% once a complete gynecologic evaluation is done, so that we are strong believers in full evaluation. And then the final comment would be part of the reason why more patients didn't fit the criteria for treatment of their pelvic venous disease and nutcracker syndrome is because, unfortunately, many of these women come in with the ovarian vein already coiled from other specialists, and in that point, there's no option for a small procedure to reduce the left renal vein pressures. Thank you.
Thank you very much, John. Go ahead, Fedor.
Yeah, that was a wonderful discussion. Our next speaker is Arjun Jairaj. Dr. Jairaj has tons of personal experience, but he also comes with the group of the Center of Venous and Lymphatic Diseases in Jackson, Mississippi, that put the iliac venoplasty and stenting on the map in the vascular surgery and continue to do wonderful research in this area. So, Arjun, go ahead with your presentation, please.
Yes, thank you. At the outset, I would like to thank Drs. Veith, Asher, Glovitsky, and Lurie for the opportunity to present in this very important and relevant webinar. Thank you. I have no financial disclosures relevant to this talk. Let's consider the scenario of a 24-year-old lady who presented with worsening back, flank, as well as pelvic pain. Her symptoms started approximately a month after her involvement in a motor vehicle collision. While she was initially diagnosed with nutcracker syndrome, she got re-diagnosed with pelvic congestion syndrome and underwent bilateral gonadal vein embolization. However, this did not really give her significant relief of her symptoms, as a result of which she underwent further embolization, this time of the pelvic varices. Yet again, there wasn't much improvement, as a result of which she was referred to our facility. To us, in addition to the symptoms I previously noted, she also had sudden episodic weakness of the lower extremity, as well as had a significantly hunched posture that we thought was related to the severe pain that she had had. Additionally, she denied any lower extremity venous symptoms. On exam, she had mild tenderness in the left lower back and flank area. Given her somewhat atypical presentation, we decided to obtain a neurology consultation. And both their exam as well as workup was negative for anything significant from that standpoint. So we decided to pursue further venous workup. The first step was to obtain a duplex ultrasound, and that revealed compression of the right common iliac vein down to 7 millimeters, and the left iliac vein was further compressed down to 5. A CT scan was subsequently obtained, and you'll notice that the scan is somewhat tilted, secondary to her inability to lay flat because of severe pain. And the scan shows a left renal vein that's not really significantly compressed, unlike the scans that Dr. White had shown. There is compression of the iliac vein, however, it's somewhat clouded by the artifacts, and she's got extensive embolization coils as well as a large Amplatzer plug, stigmata of her previous embolizations. So at this point, given how symptomatic she was, we decided to proceed with intervention. Access was obtained in the left mid-thigh femoral vein and 11 French sheath place. And this was the left iliac venogram. And you'll notice that there is compression of the left common iliac vein. There's pancaking and cross-pelvic filling of collaterals. There isn't really reflux into the pelvic reservoir per se, although there is some axial reflux in the iliac veins. The IVUS demonstrated a common iliac vein of 105 millimeters squared, which is well below the cutoff of 200 millimeters squared that we expect in the common iliac vein. The next step was to perform a left internal iliac venogram. Here again, you'll notice that there is filling of cross-pelvic collaterals, but the flow is mostly antegrade without any significant reflux into the pelvic reservoir. The next step was to obtain a left renal venogram, and here again, the flow was primarily antegrade. You'll notice that there's a large collateral channel. However, this collateral channel provides collateral for an escape channel for the left iliac segment, secondary to the stenosis that she has in that area. We proceeded with angioplasty, and you'll notice the hourglass shape of the balloon, and as it's inflated, the stenosis gives way. She had further stenosis in the caudal aspect of the common iliac vein as well, and in light of her symptoms, we decided to proceed with stenting. This was accomplished using a composite stent configuration of a wall and a Z stent. We were careful not to jail the internal iliac vein, lest she required embolization down the road. And this is her completion venogram, and you'll notice there is restoration of inline flow with very minimal filling of the cross-pelvic collaterals. So we started with a common iliac vein luminal area of 105 millimeters squared, and we ended with a 234 millimeters squared. However, 6 months on, while she had significant improvement of symptoms on the left side, she still had debilitating symptoms on the right. And so we decided to proceed with intervention on the right. And this is the venogram, and you'll notice here again, there is some pancaking of the right common iliac vein, not as bad as the left, but it's still there, and filling of cross-pelvic collaterals without any filling of the pelvic reservoir here either. And this is the left renal, left internal iliac, right internal iliac venogram, and here again there is filling of cross-pelvic collaterals without any significant filling of the pelvic reservoir. So we proceeded to perform the same angioplasty and stenting that we did on the left side. Here again, a composite stent configuration was used. And you will notice that there is restoration of inline flow without any filling of cross-pelvic collaterals on the right side. Post-procedure, she was placed on apixaban 5 milligrams twice daily and aggressive physical therapy to help with gait training as well as improve her posture. I mean, she's in her 20s. She did, however, require intervention on 2 occasions, approximately a year later, first on the left side and subsequently on the right, for recurrent symptoms, and this was secondary to the in-stent restenosis that improved after intervention. She's a few years out now and has been doing well since. So a few words on iliac vein stenting. It's important to remember that the purpose of venous stenting is fundamentally different from that of arterial, in the sense that the goal in venous stenting is to restore or reduce peripheral venous hypertension and not restore patency or promote perfusion as it is in arterial. In venous stenosis, there is a continuous rise in venous pressure with stenosis without a critical stenosis point. Additionally, comparison to an adjacent normal segment or a contralateral segment is problematic because of the presence of skip lesions, long segment stenosis, as well as bilateral disease. One can overcome this problem through use of IVUS determined normal minimal luminal areas, and we use 125 millimeters squared 150 millimeters squared and 200 millimeters squared for the common femoral, external iliac, and common iliac veins, respectively. Any luminal area below these cutoffs in a patient with quality of life impairing symptoms not responding to conservative treatment merits stenting. So coming back to our topic, in patients presenting with pelvic venous disease, it's extremely important to obtain a careful history and physical exam, as other speakers have pointed to. A comprehensive workup is important, and the SVP classification is an endeavor in that direction. The treatment should be focused on the quality of life impairing symptoms that the person has. With regards to iliac vein stenting, IVUS is essential to confirm diagnosis as well as assess adequacy of stenting. It's important to individualize stenting to the patient. Antithrombotic therapy can be selective, and post-procedure follow-up is essential. Thank you.
Well, thank you, Arjun. In our discussion is Dr. Anil Hingorani from NYU. He's expert in this particular topic and has a number of publications addressing the iliac vein venoplasty and stenting. So we're looking forward for your comment and question. Anil.
Arjun, thank you for that excellent presentation. And you bring up some really important points looking at the confluence between iliac vein stenosis and those patients with pelvic congestion syndrome or disorder. My question really focuses on some prior literature looking at the nexus between these two disorders with Dr. Papa's paper from a little over a year ago. Again, looking at the patients who had both ovarian vein reflux and iliac vein stenosis. And as you said, some of these patients actually get better with just iliac vein stenting. How do you determine which procedure these patients should have in a patient that has ovarian vein reflux that may be contributing to their symptoms and or iliac vein stenosis?
That's a great question, Dr. Hingorani. Thank you for that. I think it's important to evaluate all the systems when patients complain of atypical symptoms related to an iliac vein obstruction. As you know, iliac vein obstruction typically causes lower extremity symptoms. But if they don't have that and the symptoms are all mostly suggestive of a pelvic venous disorder, a comprehensive history and physical as well as exam is important to try to tease out what are the symptoms that truly bother the patient in a plethora of symptoms that they may have. And if there is any question about what the problem is based on, ultrasound or CT scan, then I think venography is essential. Venography and IVUS are essential. And then careful evaluation of the renal vein as well as the ovarian, the iliac system, both the external common as well as the internal iliac systems are essential. And then if the problem is primarily ovarian vein reflux, then I think the treatment should be focused on that and it should be done in a systematic manner. On the other hand, if the reflux is maybe mild, but the iliac vein compression is severe, that probably merits treatment first. So it all depends on what the history and the diagnostic testing and the venography and IVUS show, and that has to be tailored to each individual patient.
Well, excellent discussion, and I'll ask Dr. Glavitsky to continue the webinar.
Thank you very much. I'm sure that we are going to have a lot of questions to these presenters. The next speaker is Kathleen Gibson. Kathleen is from the Lake Washington Vascular Surgeons from Bellevue, Washington, and she's going to talk to us on best treatment for vulvar and perineal varices and for lower extremity varicose veins of pelvic origin. Dr. Gibson.
Hi, I'm Kathleen Gibson, and I'm sorry I'm not with you live, but I'm going to talk to you about the best treatment for vulvar and perineal varices for lower extremity varicose veins of pelvic origin. These are my disclosures. When we talk about pelvic venous disease, as you've heard in the previous lectures, there's a variety of different presentations and symptoms patients can have. What we're going to focus on in this talk is leg and vulvar symptoms. And again, reflecting the previous lectures you've already heard, The leg and vulvar varices can be coming from different anatomic sources in the pelvis, including compression syndromes, gonadal vein reflux, or both. No matter whether it's from compression or reflux, if you see varices in the vulva and leg, they are coming through pelvic escape points. And 4 of them in general are discussed: the iliac, the obturator, the perineal, and the gluteal. So we're seeing them here in sagittal section with my very, very busy slide. However, I like to see them a little bit better, or it may be easier for you to see them in cross section. The obturator and the iliac are more anterior, the perineal more medial, and the gluteal posterior. And there can be multiple gluteal escape points in reality, besides what this shows. Looking at what you see in a patient, I've got a few of my patients to share. This is one with an iliac and obturator escape point varices in the leg. This one perineal, and you can see this goes all the way up into the vulva. And then this is a typical gluteal pattern. And often with the gluteal pattern, these patients will additionally have hemorrhoids. When we're doing an SVP classification on these patients, the S, the symptoms, in addition to any pelvic symptoms they may have, if they have no pelvic symptoms and their symptoms are in the vulvar only, the symptom part is an S3A. If it is leg symptoms only, S3B. If it's both vulva and leg, 3A, 3B. The varices, if they're located in the vulva, those are V3A. And if they're in the leg, that's V3B. For the pathology, you're going to list whatever you find up in the pelvis, whether it's a compression, reflux, or both. And then in the leg, again, these will all have a pelvic escape point. And it will either be bilateral, in which case you'll say B, pelvic reflux and non-thrombotic, or it'll be right or left. So in deciding how to best treat these patients, how do they present? What are their characteristics? Well, we did a study in our practice. It was published in 2017. We took 72 women with symptomatic vulvar varices, and we compared them to over 1,000 women during the same period that did not have pelvic source varicose veins. The mean age of these women was younger than what we see in our varicose vein population. They had had 3 births, which was higher, and the mean baby weight was higher than what we see in the general population. So women with more children and larger babies, and they were thin. So the mean BMI was 21.9. Their symptoms were very similar to what we see with leg varicose veins: heaviness, aching, throbbing. Itching wasn't one of the top ones listed, but otherwise very similar to what you see for other venous disorders. And when we're talking about these women that ostensibly have pelvic varices, surprisingly, they don't have a lot of pelvic symptoms most of the time. About a quarter of them noted some dyspareunia, but in terms of saying that they had pelvic pain, only 7% did. So this kind of leads into how you treat them. Do you treat them by their anatomy, or do you treat them by their symptoms? And I definitely have an opinion on that. So when do I treat them from the top down? Coil embolization. Well, first off, in terms of helping leg and vulvar symptoms, treating from the top down doesn't always make that part better. In fact, there is some paucity of data, but there is some data of people looking at this where they coil embolized from the top for treating, and almost all these patients would need a second treatment to treat from the bottom up, even if you did a coil embolization or a stent. I treat with coils or stenting from the top down when the primary thing that the patient is complaining about is pelvic, flank, low back, that's their main complaint. Or if I've treated them from the bottom, treated the vulvar or leg veins, and they have not gotten better or recurred quickly. So a case example, this is a 42-year-old pediatrician that's had 2 children. She has vulvar and medial thigh varices that developed in her second pregnancy, and her primary complaint is extreme vulvar itching. She'd had multiple courses of anti-yeast treatment. She said this is worse with menses, and she had throbbing in her upper inner thigh veins. She had no edema, no activity limitations, and no pelvic symptoms. And the topical meds prescribed by her OB/GYN had not helped. This is what she looked at. So she's got medial thigh and vulvar veins. Her duplex ultrasound shows this pelvic source varicose vein here in pink comes down and joins a segment. She has segmental incompetence of the great saphenous vein. Her great saphenous vein did not have varices coming off of it. She did have some SSV reflux. Again, this was asymptomatic, so not what I targeted. Looking in her pelvis, she had everything. She had her left renal vein was compressed. She had a large ovarian vein. It was 11 millimeters. She had compression of both the right and left common iliac veins, but no symptoms in that area. So looking at her SVP class, the S is 3A, meaning her main symptoms were in the vulva. So you could do all kinds of things based on this anatomy, but would any of these things be appropriate? I believe we treat the patient, not the image. And this is my protocol for vulvar varicose veins and veins in the leg that come from a pelvic source. So if they're asymptomatic or minimally symptomatic, you don't need to treat them. If they're symptomatic and they've got pelvic symptoms predominantly, do coils and sclerotherapy, or if they've got a nivel lesion that's symptomatic and you think that's the cause, then they'd get a stent. If they have no pelvic symptoms, then they get sclerotherapy from below. Again, treat the patient, not the imaging. And this patient we just talked about has no symptoms of the compression being symptomatic, no symptoms that her renal compression is symptomatic, and no real pelvic symptoms. So what I did is I treated her in the office, and my standard technique is use a small needle, ultrasound guidance. This can also be done with fluoroscopy, although that's not how I do it. I use polidocanol mixed in a 1:4 ratio with oxygen and carbon dioxide. It's important that the patient's comfortable. I use a warm gel with step off. I have an RVT helping me because each one of us kind of flattens the skin. I use a hockey stick and occasionally not in the vulva itself, but in the leg. If there's really large, unusually large branches, I may accompany this with some phlebectomy. They have normal activity right away, and I have them wear Spanx or a kind of compressive underwear for 2 weeks. So this is an example of ultrasound guided sclerotherapy in the vulva and using a small needle. And the vulva is a little tricky because it tends to be mobile. That's why I think 2 sets of hands help, or really kind of stretching the skin. And you can develop expertise in this area. So this is the same patient after treatment. And of the 72 patients that were in our study, I did not put this as part of the paper because this was the second part of following them. And we did 51 patients were treated, and we had complete resolution of symptoms in 68% with 1 recurrence that needed some more sclerotherapy, and 29% were improved. And of all the patients we treated, the 51 that got treatment, only 2 of them went on to needing pelvic intervention, either because they developed pelvic pain later or because they had early recurrence. So in conclusion, pelvic source veins of the perineum and vulva and thigh, they have a common anatomic source with what we used to call pelvic congestion syndrome or pelvic venous reflux, but the presentation can differ. And most of the time in my practice, these patients do not have pelvic pain. About 7% did. Treatment methods may vary. There's no data that tells us the best way to treat these patients, but I can tell you in my practice, I've had very good success in treating them from the bottom up with sclerotherapy. We need to use disease-specific assessment tools, and those are being developed. And I think we do need to consider costs, because you can do many sessions of sclerotherapy for the bottom, would be much cheaper than doing a coil embolization from the top. So I do thank you for your time.
Thank you very much, Dr. Gibson. This was really an excellent presentation, a topic not many of us is familiar with. We have a real expert who is going to be our discussant, coming from Poland. Aleksandra Jaworucka-Kaczorowska is a physician who works in the Center of Phlebology and Aesthetic Medicine at the Jaworucki Surgery Center in Gorzow, Wielkopolski. Aleksandra.
Thanks a lot for the invitation. It's really an honor for me to be here with you. It is a very important topic. As you know, that there are men, women and men with pelvic origin varicose veins, and most of them do not have pelvic symptoms, as Caitlin Gibson said before. And the treatment, of course, is still discussed, as there are doctors who suggest top-down treatment of such pelvic veins because this is the reason of varicosity. So they perform pelvic vein embolization or treatment of iliac or renal vein compression if it is the cause of pelvic vein incompetency. The others, as Caitlin and me, propose bottom-up treatment, so minimal invasive treatment from below. The need for pelvic vein treatment in patients with pelvic origin varicose veins has not been established reliably. Based on the studies, varicose vein disappeared in only 14% of patients after embolization, and 54% of patients had a recurrence even though they had an embolization. So I see a lot of patients, usually young women, with after several embolizations, and the varicose vein did not disappear. So my question is, I very often perform venography through the pelvic escape points in patients, especially in patients after embolization. And when you see the contrast is going to the coil, so do you have any clue or suggestion why the coils do not close the varicose veins in that area? So what is the reason? What's the point? I know that Caitlin is not with us, but maybe you have because sometimes we do embolization of ovarian vein. The second embolization is a pudendal vein. The next embolization of all tributaries, and there are still varicosities. And you put and you give the contrast, and you see that the veins, the contrast goes to the stent, to the coil. So why it doesn't close it?
Well, we have several of our panelists do embolizations. Any of you would like to chime in and try to give an answer to Alexandra? Dr. Asher, do you have an idea why embolization doesn't cause complete occlusion?
I thought I was your friend, but you put me in the spot now. But I have to tell you that my experience with embolization in the arterial system has taught me the one thing, that the coils do not really all the time do the job they're supposed to do. For example, they tend to match together in one area and leave another space within the vessel that allows the flow to go, and it does not thrombose. So just because you put a coil there does not, unless you pack it in, is not necessarily going to obstruct. Now, what this has to do with the clinical presentation of a patient, most of them, I think, when they get coil embolization of the ovarian veins, and that's the reason, they tend to improve. But I think the point raised here is that it may have to do more with the stent, with the coil not thrombosing the vessel.
Yeah, but it is really interesting. Then in so many cases, you can't close these varicose veins even though you do embolizations. That's why I think we shouldn't do embolization in patient who doesn't have symptoms, pelvic symptoms, and only varicosities. So we should treat them from below. That was the point of my question. So don't put so many coils in the patient who doesn't have symptoms in that area. Just close it from below, because the coils won't close these varicose veins, and they are young.
Can I just ask a question also, just on follow-up with this? Why the escape points only are evaluated and taught for patients who actually don't have symptoms, pelvic symptoms, but they have vulvar varicosities? There's any other place that we should be looking more into those escape points and see what their impact are in terms of the patients getting better or not?
Alessandra, you have an answer to this?
Because I see so many people with pelvic origin varicose veins, I always check pelvic escape points in all patients, always during ultrasonography. I think we did the not improper diagnostic before, because we are saying that only 3.1% of patients had a varicose veins of pelvic origin, but I see that there's definitely more. So I think it should be checked all the time, this pelvic escape points in all patients with varicosities.
You agree that the most common points, the most common refluxes are within the peroneal and the femoral, while the gluteal is just not very common. Is that true in your experience?
Yes, it is. Definitely perineal, clitoral is also very common, and inguinal are the three most common pelvic escape points. So
right.
these are.
Thank you.
Thank you. I think, many of you have several questions. Let me start the discussion with a question to Dr. Jayaraj about stenting the iliac veins. You really showed very nicely, you placed your stent in the common iliac vein and you seem to preserve the pelvic outflow. But most people, when they do iliac vein stenting, they actually jail the internal iliac vein. So is that a potential problem in this type of patients where we actually want to improve the outflow from the internal iliac veins? Or do you have a technique of how to avoid that?
Thank you for the question, Dr. Levitsky. Yeah, that's an important point. I think it all boils down to the symptoms the patient is presenting with. And in an overwhelming majority of patients, iliac vein obstruction generally tends to cause lower extremity symptoms. And so pelvic venous symptoms are relatively rare. And so, our practice and many others, end up stenting the entire iliac segment, because if you have an obstruction in the external iliac vein, you have to fix it. Otherwise, the patient is not going to get better. But this particular patient and a few like her is a very atypical presentation of iliac vein obstruction, and the symptoms are all pelvic in nature. And so there is always the possibility that the internal iliac or reflux in the internal iliac can lead to recurrence of symptoms down the road, or it could be the primary problem too. And so jailing it is probably not a great idea, because theoretically you can, depending on the type of stent you put, you can like fenestrate and get through the stent into the internal iliac. It's technically quite challenging and you may not always be successful. And then you really don't have an alternate way to embolize the internal iliac vein. So I think in people with pelvic venous disorders, you have to be very careful of how much of the iliac vein you stent. Just stent enough so that if you have to come back later and fix something else, you have a way.
Yeah,
Thank
Peter,
you very much. Yes, go ahead.
I have a question.
Go ahead, Frank. Go for it.
For Dr. White. Your operation was beautiful. How do you do a post-op venogram? Where do you inject to get visualization of your transposition?
A good question, Frank. We just inject into the left renal vein. If our diagnosis is right, if you inject, and we hand inject only, no power injection, but if you hand inject in reverse Trendelenburg into the renal vein, you should see the contrast going down the ovarian vein into the iliac vein.
But post-op, how do you get the dye into the ovarian vein? Because it's not hooked up to the renal vein anymore, it's hooked up to the iliac vein.
No, that's the distal end, Frank. I'm sorry to confuse. So the distal end of the ovarian vein in the pelvis is moved over. It remains connected to the renal vein superiorly. So blood goes from the renal pelvis down the ovarian vein into the iliac vein.
Okay.
Neil, you have questions, please go ahead.
Yeah, thank you, Peter. And I thought since Dr. White was answering questions, I'd ask him some as well. Sorry about my dog barking. My question for him relates to both selection of the patients and perhaps alternate approach. I think the idea, though, the challenge with these nutcracker patients is to try to do something that's safe and effective. And I think this concept of ovarian vein transposition, so to speak, is an excellent one, and one I strongly support that he continue to evaluate. One of the issues, though, is that the coexistence of a compression of the renal vein and of the left common iliac vein is very high. And so how do you select patients for this procedure with that in mind? Clearly, there are going to be some patients that have what might be borderline compressions that could become significant compressions that may affect the drainage of the kidney and the leg when both are draining through the same conduit. And then the other selection question is, do you think there's value in doing pressure measurements of the renal vein to distinguish those that have significant appearing imaging compression, but not significant hemodynamic compression? And then finally, is there a value or is there a role for laparoscopic approaches to this kind of approach, just to make it even more appealing? But I appreciate your talk. It's a great concept.
Thanks very much. To address those issues, we have been fortunate that we have not seen women with high-grade compression of the iliac vein and the renal vein simultaneously. And the way we make the decision is, Dr. Jairaj had mentioned it, is that it's all dependent on collateral flow. Just seeing a stenosis does not mean that there's obstruction of flow. If there are multiple collaterals originating from the iliac vein, for example, distal to the obstruction, then we believe that that would be a hemodynamically significant compression. Same with the renal vein. If we don't see any escape flow from the renal vein, it doesn't matter how bad the compression looks, we would not treat those patients. So we would decide, based upon the collateral flow. Now, in the unusual circumstance in our practice where we would see both, I've had the opportunity to discuss this with Dr. Jairaj. We would consider stenting the iliac vein and then carrying the transposition a little more distally, so that we could plug into the iliac vein distal to that. And I think that that's probably reasonable. In terms of alternative methodologies, actually our first report on ovarian vein transposition was robotic, where we just made a very tiny incision and freed the entire ovarian vein, prepped the iliac vein, and then just did the anastomosis through a tiny skin incision in the left lower quadrant. I believe that once there are adequate vascular clamps that can be used, yes, I do believe that this will become an even more minimally invasive approach. So, that's the way we would handle it. And our preference is to use shorter stents. And I know that's somewhat heretical because of the risk of stent migration. But the way we have decided to solve that problem is we place an option IVC filter right above the stent. So it's either right above the renal vein or right above the iliac vein. And then we stent, and then we follow that patient for 6 weeks. And if there's no movement of the stent at all, the option filter comes out. But these are young women, and while the risk of stent migration is only about 5 to 6%, it can be catastrophic. So those are the approaches we use.
Thank you very much, John. I have a lot of questions that's coming in, Fedor, from our viewers, and maybe I just let me combine a couple of them. David Siegel and Dr. Ali Rana, for instance, would like to really know how to prioritize between May-Turner and ovarian vein reflux. So maybe Neil, do you want to tell us how you would prioritize between ovarian vein reflux and May-Turner?
Sure, thanks for the opportunity. And I think I may be repeating what Arjun said as he addressed this. And I thought as he was addressing this in his response to his talk, I thought he did an excellent job in trying to tease that issue out. I think just to summarize, the two occur frequently together. So retrograde flow in the ovarian vein without a nutcracker compression, filling a pelvic reservoir and causing venous hypertension, and then also the iliac vein obstruction. And I think maybe a simple way of looking at it is some of these patients may need to have both things treated, but what you treat first should be the thing that you think would be the primary pain generator based on the patient's clinical presentation as well as the imaging. And I think getting more granular than that would take up way too much time. I'll leave it at that. And if you'd like to ask Arjun to elaborate a little bit more to take it beyond there, that would be fair.
I understand Alessandra has a question.
Yes, I have a question to Dr. White, because it's very interesting, the diagnostic process you mentioned. And also what mentioned Neil, that there are so many comorbidities and other diseases which may cause pelvic symptoms. So you said that all your patient has laparoscopy, gynecological laparoscopy, did I understand correctly, before you do the pelvic treatment?
Yes, the vast majority of our patients do. But I will tell you, because it's so difficult to diagnose, the vast majority of our patients have seen 8 gynecologists before they get to us.
Yeah, I know, but I am the gynecologist, and it's very interesting, because in Poland we do not do so many laparoscopies because of pelvic pain, and usually when we see the varicose veins in that area, we send the gynecologists send it to vascular surgeons or to me to do in pelvic vein embolization. So I think that this diagnostic process should be really clear for everyone. What should be done? What examination should be performed? What should we do? Of course, ultrasonography doing by gynecologists is an obvious because you can find everything there. It's a basic diagnostic process. But the laparoscopy is very interesting, because we know that endometriosis is very often not visible when we are doing ultrasonography. Also, when we do MRI, on MRI we can see only 0.5 millimeters endometriosis or more. And you can't see adhesions, which are very often the cause of pain. So maybe it should be also mentioned that diagnostic laparoscopy is a good option for these women.
Right, we would agree with that completely.
Thank you.
I have a question about diagnosis. Is IVUS of the left renal vein a requirement prior to treatment of pelvic venous disorders with ovarian vein embolization or nutcracker? Should we get IVUS on everyone, John?
We do like IVUS. We don't rely on it solely because it can be a little bit challenging at times. It's wise to remember that the size of the renal vein, the diameter of the renal vein, changes dramatically depending upon hydration status, depending upon position, depending upon respiratory cycles. So we like IVUS to give us real-time information of the status of the renal vein at that time, but we compare it to the appearance on CT scan as well. So we like to back it up.
What about duplex scanning? We transabdominal duplex, we use that, and we look at the ratio of flow velocity in the renal hilum or IVC and at the site of compression. Do you use transabdominal ultrasound?
Yes, we have, but I must admit that's once again operator dependent. It depends on the skill of your vascular tech to really image those vessels and record the velocities. And I would tell you that the vast majority of patients that come to see us come from institutions where that's not easily accomplished, but that is a good test to help with it. I think you still need a more anatomic imaging study to plan your treatment, though.
Which anatomic study do you prefer? Do you prefer MRV or CTV or both?
I believe that since reflux is a gravity-dependent problem, and since both of those tests are supine, there are some that prefer MRV, some that prefer CTV. I like CTV, quite honestly, because I can interpret my own images a little bit more easily. And that's my own limitation. Because MRI can show you directional flow, many people find that extremely helpful.
I have a question for the, if I may, for the moderators. Do you think that this particular subject is complex enough that a person who just finished a fellowship or a young surgeon needs some extra training to be able to discern which patients actually can have one of these procedures? Do you think they need an extra training for this, Peter and Dr. Lurie?
Well, I think we are getting to the point that this obviously is a multidisciplinary problem. So maybe certainly in leading institutions, you need centers and multidisciplinary groups to deal with this problem. I'm sure it needs special training, whether we should have a chronic pelvic disorder fellowship. I am not sure we are there yet, but it clearly needs expertise that we don't necessarily learn during a vascular surgical fellowship.
I agree with Peter completely that that's a multidisciplinary approach. But you know, the OBGYN started the chronic pelvic pain fellowships a few years ago. So, and they recognized that this is the area that regular trained OBGYN is not really prepared for the practice. So it's a quite narrow area in their specialty. I think it's the same issue in our specialty where the just graduated fellows have very little education in this area. Sarah, you raise your hand. You want to address the same question?
Yes, I thought I just would make a comment, having relatively recently finished my training, and actually in the UK in vascular surgery, this would not be part of the standard curriculum, and phlebology comes under the umbrella of vascular surgery in the UK, so we're all trained in superficial intravenous disease, but the compression syndromes are certainly something that is seen a little bit more like a niche or an esoteric area in some aspects. So they wouldn't be part of the standard curriculum. So certainly any of us who have a specific interest would either need to be in a tertiary or quaternary center where you have the MDT set up to see those cases and discuss them with all the appropriate people. Because I think that what has been said before, and I echo, is the fact that, you know, just because you find an anatomical abnormality doesn't necessarily mean that that always needs to be addressed. And you need to have a very careful and standardized approach to the patient assessment and do the right thing for the right patient to improve the symptoms as much as possible. And that's doesn't mean, you know, coiling every refluxing vein or stenting every compression that you see. So yes, further experience would be required, I think.
Dr. Veith?
Yeah, I think this has been a really great webinar. I have one quick question for Dr. White. In your operation, you relieve the congestion in the kidney, but might you not make the congestion in the pelvis worse? Because you can have no outflow even when lying down through the renal vein.
Right,
Through
so
the ovarian vein.
So what we do, Frank, is just above the division of the ovarian vein into the pampiniform plexus around the ovary, we ligate the distal ovarian vein. So the main refluxing blood that's coming down the ovarian vein and going into these small vessels that causes the pain, that flow is eradicated. So we ligate the distal ovarian vein, we divide it, and then we swing the proximal end of the division onto the iliac vein.
So where does the blood go from the ovary?
Well, so
collaterals across the way.
Yes, these women get a torrent of blood since the kidneys get about 12% of the cardiac output. So those women, their pelvis has already figured out how to handle this torrent of blood coming down. So if you just ligate the major influx, you leave enough outflow through those collateral veins to provide adequate venous drainage from the pelvis.
Okay.
Thank you very much, John. That certainly is always a dilemma, whether you transform a patient who has reflux to a patient who now has obstruction. And I think that certainly justifies Dr. Veith's question. How do you really determine that? I think this has been an amazing seminar, and we have a lot of questions that I will ask the faculty to answer written. And we will ask now Dr. Asher to conclude the webinar.
Peter, thank you very much. Like you said, this has been a superb and spectacular webinar, has addressed many points that I'm sure vascular surgeons and vascular specialists and gynecologists who were in this webinar as well were satisfied with. The problem was posed very nicely by the speakers, and their solutions were excellent. I want to particularly thank you for organizing this, for writing this program, and every speaker and discussant immediately accepted to participate. They realized the importance of it. And for Dr. Fedor Lurie, who is a major expert in this area as well, I want to thank him personally. Remember, this is a society that was created to honor Professor Frank Veith, who has dedicated his entire life to the betterment of the vascular patient. And I'm so happy to have him here today with us. It's always been a pleasure and honor to have him. And I want to thank you all for being in this webinar. We had one of the most attended webinars that we have organized, and we have organized over 30 of these. So thank you very much, and I hope to see you very soon in our next webinar. Thank you. Bye-bye. Bye-bye to everybody.
Thank you.
Thank you. Bye-bye.